Alliance Live, Self-Management Week, Professor Lisa Kidd, Glasgow Caledonian University. Courage, Confidence and Collaboration, Supporting Self-Management in Health Professionals Practice.
What I do as part of my day job is mostly stroke research. And I'm going to draw on some of the work today, specifically around supported self-management in stroke and how health professionals can better support self-management and what this might look like or involve in our practice. Hopefully today's talk will connect with you, and hopefully as I speak, the title of my talk and the importance of courage, confidence and collaboration will become self-explanatory. So first of all, as a researcher, I'm duty bound to be transparent and disclose my funding sources and any conflicts of interest. I've no conflicts of interest to declare, and I haven't received any personal finances for any of the work that is going to be presented today. The work that I will talk about, however, has been funded by various funding bodies, including Stroke Association, the Burdett Trust for Nursing, and the National Institute for Health Research. Of course, the work here and the work that I do wouldn't be possible without a whole host of collaborators and patient partners, and I will introduce you to them later in the talk. But I'd also like to acknowledge that the work I present here today, whilst informing our research and practice, it comes at a cost for people who are living day in, day out with the impact of their stroke. And I just want to publicly thank them for their openness and their sharing of their experiences so generously with us continuously, and for trusting us to appropriately and meaningfully share these insights with the healthcare community and beyond. And I do have one final, slightly unusual disclosure in that it's not quite the usual kind of disclosure that you would do at a conference or giving a talk like this, but that is that I'm predominantly a qualitative researcher. And by the very nature of that, I love to talk, as you will see. But I also have a lot of quotes and insights to share during the talk today. So I hope your eyesight's up to the job. Hopefully in this webinar format, you'll be able to see all the quotes and the words clearly. But if not, then please do let me know, because I'm very happy to share the slides to anyone afterwards. So, as I mentioned briefly at the start, today's talk is grounded in a programme of research on supported self-management in stroke, which we've been building for over the past kind of 10 years or so here in Scotland, and it's involved international collaborations, and it's led to real changes in the culture and practices of how people are supported in the longer term after they've had a stroke here in Scotland. And what I intend to convey today in this talk is a set of principles and values for guiding care delivery and how important the fundamental ideas of having courage and confidence and working collaboratively with stroke survivors and family members in inspiring practitioners to work differently and flexibly to more meaningfully address their needs and priorities for life after stroke really are in this space. The work that we're doing is still very much a journey of discovery and learning with curiosity from stroke survivors, practitioners, policymakers, and other academics. So I don't have all the answers to share with you today, but I will fill in some of the gaps and hopefully raise some points for further conversations. So let's start with a bit of scene setting around supported self-management. I mean, as a concept itself, it isn't new. It's been around since the 1970s, and we talk about it ad nauseum, possibly without really understanding what we mean by it as well. But its underpinning principles and ethos has naturally evolved over the past 2 decades, I would say. And over that time, we've seen a squeeze on resources, an increasingly aging population who are now living longer with multiple conditions, increasing demands for and expectations on health professionals' time and roles, but also for stroke survivors and their families, and the idea of self-management to help support people and to minimise the burden that they experience after a stroke have become increasingly common rhetorics as a solution for addressing some of these challenges. And of course, we now have the fallout from the COVID-19 pandemic to consider as well, and the impact of how stroke care has had to be managed and delivered during that time, with many people, as you'll know, not receiving the quality and the quantity of the usual care and rehabilitation that they might have, and in which we now have an increasingly burnt out workforce who are now attempting to pick everything back up and redress these impacts. Narratives around self-management are also shaped by other movements and agendas. For example, we've just had recent guidelines published in the field of stroke, new national guidelines in the UK, and we've got living guidelines in other countries such as Australia. And those guidelines are all calling for this increased intensity of rehabilitation and therapy that people should be getting after a stroke. And despite concerns round about the quality of that evidence, it's possible that supported self-management again becomes seen as a plug, as a vehicle for increasing therapy time and for asking people to do more things away from the hospital or rehabilitation setting. And I'll come back on to that challenge as we talk through what supported self-management looks like. And I'm sure you'll see how the way that we conceptualise it and think about it in a broader sense kind of jars with that idea. So that brings me quite nicely onto how we do view supported self-management in contemporary stroke rehabilitation and also in other forms of rehabilitation and in other conditions as well. I'm obviously talking mostly from the lens of stroke and stroke rehabilitation today, but I think there's a lot here that has transferability across different areas in which we work or different conditions that people with lived experience are dealing with and managing. But supported self-management is such a multifaceted and diffuse idea that I guess it's no surprise that there have been all these countless definitions about what it is and different interpretations of what it comprises. And all of this leads to a whole lot of confusion and ambiguity. And I think that's a lot of what we're trying to unpack in health services, healthcare provision now, as supported self-management becomes a much more desirable and fundamental component of what good quality long-term condition care looks like. Of course, for people with lived experiences themselves, self-management is just what you get up and do every day. It's not seen as something new, something different. But I think in terms of healthcare provision, it's quite often been seen as a quick fix or a quick win or a way to tailor services so that you can prioritise resources a little bit more. And certainly this more holistic idea is how we've conceptualised supported self-management in a guide that I was part of the writing team for the Health Foundation back in 2015. And what we kind of see it as being is this partnership working with stroke survivors and their families. It's an ongoing relationship with people through which we can help facilitate skills development and confidence building, but it also incorporates the uniqueness of people's own experiences and the realities of their day-to-day lives, their sense of identity and their priorities, and fitting back in with valued roles. So they're very much around their priorities of what they want their lives to look like and how can we help support that. And that idea is very much informed the underpinning ethos of Scotland's new vision for a progressive stroke pathway and the accompanying revised stroke improvement plan that has just been published and are being rolled out over the next few months and years. But certainly we're doing a lot of work just now over the next few months to support staff to think differently about how they can work in partnership with people. And in this model, we frame self-management as not just being about relevant at the time of discharge from hospital or community services, for example, but it's not just about us having a role in signposting onto elsewhere, and it's definitely not about expecting people to go away and just get on with things themselves. So already maybe you can see the challenges with some of those notions coming through in the other guideline work about potentially where supported self-management will be used as a plug or a quick win. And it's also not about compliance with our professionally driven treatment plans, but rather how we're framing this is supported self-management as a whole person approach, where the delivery of care and support very much aligns with the values and things that are important to people and the ways they want to live their life and reclaim their sense of identity after stroke. And I'm not going to say too much about these new stroke policies and plans today, because this is a bit of a broader talk, but I'm very happy to speak about these with anyone who is interested. So please do email me or get in touch. And against this backdrop, when we think about the evidence for supported self-management, as practitioners, we are all very much about evidence-based practice. We are, constantly being encouraged to work in evidence-based ways. But the evidence base on self-management has at the moment largely focused on the effectiveness of different kinds of structured self-management programs. So some of these are cited here. These have been put into published papers, and there's some well-known ones there now, like the Take Charge program, which has been trialled in New Zealand, and in the UK, we've got a growing evidence base round about the Bridges self-management programme, which was established by Fiona Jones in London. So some of you might have heard about some of these, and some of these might be quite new for you. But most of these approaches comprise different formats of delivery. Some are face-to-face, some are online, some are delivered to individuals, others delivered in a group format, and they all contain elements of personalised goal setting, education, and activities that are designed to help stroke survivors to build confidence, to articulate and work towards their own personalised self-management goals. And you'll see similar kinds of structured self-management programmes across other conditions like diabetes and arthritis, and MS, and growing into those kind of spaces as well. But these are the ones that we know about and have a growing evidence base on in stroke. And there's also been systematic reviews that have been conducted trying to pull together the evidence and offer some more conclusive recommendations for what the evidence base is actually suggesting. And what the evidence base suggests, these reviews suggest, is that these structured self-management programs can improve quality of life, they can improve self-efficacy or people's confidence, and also help improve mental well-being and potentially reduce the amount of times that people have to be in hospital. So these programs and interventions are an important part of our stroke self-management landscape, but we don't fully yet know how they integrate with usual care and how they impact on the healthcare system that we're working in, and actually how they impact on patients' experiences or outcomes on that larger scale. And as encouraging as these programs are, and their evidence is, they unfortunately are just one piece of the puzzle, and they don't encompass that full landscape of what supported self-management provision looks like and what's happening out there right now, largely for us working in stroke within our community-based support provision. And this mostly involves things like one-to-one follow-up from nurses or other rehabilitationists and the healthcare teams, and some wider engagement with maybe peer support groups or third sector and charity groups that are providing a lot of this support in the community, or even kind of linking in with our colleagues in social work as well. So it's quite a messy and complex landscape that this evidence doesn't quite tap into, and we need to be thinking more about actually how we capture the real life experiences of how supported self-management works for people and what it should look like. And unfortunately, as many of you will know or have experience of yourself, that what happens in clinical practice can often feel quite disconnected and removed from how we frame and view this ideal model of a relational and partnership-based approach to supported self-management. These quotes here, which I hope you can manage to read them, are the voices of people affected by stroke from some of the research that we've undertaken with different people over the last 6 months or so. And what they tell us time and time again is that people often feel like they're suddenly on their own after discharge, and that there's no one there who can consistently support them. And I'm sure that's not unique to stroke. I'm sure everybody coming out of hospital feels has a similar experience or story to tell around about this. There's been a large piece of patient experience work that's just been conducted in England by the Stroke Association, and sadly that reinforces this picture that people just don't feel involved enough in their stroke journeys, and that getting on with and reclaiming their lives after stroke continues to be that comparatively neglected area for both research and for stroke services as well. So we're still not getting it quite right. And what these experiences tell us is that to live well after a stroke survivors need more, which goes beyond just education, information, and teaching and guidance in the technical skills of how to self-manage. But it also involves approaches which recognise and help people to re-establish their sense of who they are as a person, their identity and their purpose in life, and also which reflects their perspectives and interests in what they want to get out of their lives, and provides support that's ongoing along that pathway or journey through kind and compassionate and collaborative and trusting relationships with health professionals that mean that they're just not left to get on with things alone, and that they're not involved in their care as a result, and decisions that ultimately will affect their lives and are theirs to be making. And what they show is the importance of that ideal model of supported self-management that I was talking about back at the start. However, implementing and embedding this model, which can often involve a very different way of working for health professionals and a very different way of delivering services for healthcare systems, it can challenge us in our practice and in the services that we're trying to deliver. I'm sure many of you will experience the daily challenges of enacting person-centred within the existing systems and models of care that we work in. And for those of you with lived experience, you might have experienced that lack of person-centredness at times. I know that when I have been involved with health services, I very much have experienced that lack of person-centredness. And as a researcher in person-centred care, of course, that's going to be the thing that I most often hook onto with my experiences. But again, for the keen ones amongst you, I'm sure that you can already see again about how this idea of plugging self-management as that means to increase therapy time, for example, or address reduced levels of staffing or capacity within the system, jars with this more holistic, relational and person-centred ethos that of supported self-management that people want and need. And as a result, supporting self-management is quite often seen as just a nice to do, an adjunct to what we already do, or just simply at odds and just not feasible to do at all within our healthcare systems. In stroke care, for example, we have a set of evidence-based components for what acute stroke care should involve. So you have a stroke, you're admitted to a stroke unit, and there's a set of criteria or things that you have to get in a particular time. Unfortunately, we don't have anything like that for community stroke care. So we're all still a little bit at sea trying to work out what's going to work for people, what should community stroke service provision look like, how do we support self-management in the best way? And there's significant variation in how community stroke care services are organised and delivered, and what teams look like in terms of staffing and skill mix, or whether they're stroke specific or generic, and whether early supported discharge, for example, is something that's provided or not. So there's a lot of ambiguity and confusion in that space about when and how to do supported self-management well. But there are a lot of people working in this area just now to try and make community stroke services and that long-term provision of care and self-management support a bit better for people. But these boxes here talk about they're the experiences of therapists that we've worked with in our research. And they show that there's often this expectation or mandate to deliver supported self-management, but without that real understanding about what it involves, both in terms of its actual delivery and the training and skills that we need to do it. But it also highlights that the work that needs to be embedded underneath this to support and prepare teams for having that shared sense of direction, purpose and understanding, and the skill set and confidence to work differently when required, so that they can truly respond to people's needs in a way that's right for them, rather than just sticking to the service model and the things that are easy or best fit to do. And so it's with all of this in mind that in our programme of work, we started to think about the need for a step change and how we could do things differently in order to truly involve people in their care and put their priorities at the heart of what we're doing. The evidence that we have already is of course essential, but we also need to look broader than this towards research designs, for example, in my line of work, that allow us to study that complexity and murkiness over what's happening in clinical practice. Interest in supported self-management will continue to grow, and it won't go away because it's what people want and need. And it's increasingly being delivered in some form within different clinical services, but more in that kind of ad hoc and potentially unreplicable ways. Perhaps some of it's quite small scale. We know from some of the projects, even that's kind of funded through the Self-Management Fund as well. A lot of those are small scale projects, but have the potential to grow arms and legs and be replicated and transferred into other settings as well. And I think that's what's so exciting about the fund and the projects that come through from that. But we also need to gather this evidence about how effective these different approaches are, how we can scale them up to work in different places, and how they might work differently in different places as well that have different environmental contexts. For example, what works in an urban setting, a city centre setting, might be quite different from what works in rural Scotland or the Highlands of Scotland or the Islands of Scotland. And so we need to take that into account when we are designing and delivering services that are actually going to help support people's self-management so that they have a chance of being implemented and won't just be risk being considered wasteful. And so it's from this starting point, really, that we've been exploring through our programme of research how we embed this kind of model and supported self-management in clinical environments and make it an everyday part of how health professionals work, rather than just an isolated task or activity that we do as part of our jobs. And this slide represents a synthesis of these contemporary notions about what supported self-management is and involves. Our recent evidence has shown that when supported self-management works well, it's because as health professionals, we're working to deliver it as a team, and we're working consistently in ways that are underpinned by similar principles or values to support and reinforce that shared sense of purpose and understanding around what supported self-management is and looks like for the team and for the people that we're working with. And there is that fundamental change in the relationships that we have with people, moving away from that sense of doing things to people, and acknowledging people's priorities and the assets and the skills and experiences and insights that people themselves bring through their lived experiences, and acknowledging our roles as coaches rather than the experts who hold all the knowledge and power. And it's also about moving away from this notion of empowering people. Those of you who've heard me speak before or who've chatted informally with me about this will know that I have an issue with the idea of empowering people, because people already have their own sense of power. So rather than us thinking that we should be empowering people, it's actually transforming that and thinking about ways of working and building relationships with people that protect and strengthen and don't diminish the existing sense of power or agency that they already have. And when we work in this way, that creates this safe and collaborative space where stroke survivors and their families feel a real sense of ownership over what's happening to them and a sense of direction over their lives and how they can help shape that and start to lead that, rather than health professionals being the ones that are telling people what to do and when. But of course, this isn't intended to completely ignore the personal fears and challenges that as health professionals we can face in working in a different way to what we're used to, or to maybe how we've been trained to. And I think a lot of these is what holds health professionals back from truly engaging in this more collaborative space. A lot of it is the systems we're working within, which don't always make it easy to be as person-centred as we would like. But also we have fears about what we're doing as well, and working collaboratively with people can be quite daunting if we don't have all the answers to people's questions or we're able to respond immediately to people's needs. And it can also be quite difficult to step back and let people themselves be in control, particularly when this might involve different ideas to what we as professionals would have, or if it involves some kind of risk-taking of sorts. But what I want to say is this: all of these fears are okay, and it's okay not to have all the answers. Yes, people value our expertise and our experience as professionals and want to trust that they can trust that we know what we're doing. But that trust also comes from working collaboratively with people so that they feel heard and listened to, and that the responsibility for their self-management is not solely theirs or ours, but it's actually shared between us both. And that allows new ideas to be tried and tested, and permission to fail, to try something and for it not to work out or not get it right, but to pick up the pieces and have a go again. And that's how we all learn about what works for us and what doesn't. So it makes sense that that is what supported self-management should be providing a space for as well. And hopefully now you'll see that where the title of today's talk comes from, because in order to do supported self-management well, as practitioners, we need to feel courageous and we need to have confidence and we need to work in collaboration, both within and across our teams, the people that we're working with, but also with stroke survivors and their families. And I think turning this on its head as well, these are the 3 C's, I think, are what's important to people with lived experience as well, in terms of them tackling their self-management and working on, how they want to live their lives and telling us how they want to be supported in doing that. But if we look from a health professional perspective at the moment, how do we become confident and courageous in what we're doing? And actually, a lot of this comes down to how we work within our teams, how we develop a sense of a shared understanding about what it is that we're working towards together in terms of supporting people in different and more person-centered ways, and the assets that we bring to that and what the team environment offers us as well. Our research identified that embedding supported self-management into service delivery models is less challenging when we're supported and enabled by the culture around us. And where there's a genuine push towards implementing person-centered care approaches that go beyond metrics and measurement and mandated policies, and where stroke survivors' voices and experiences are truly valued and prioritised in shaping what care delivery looks like. And achieving this sense might involve the work that leaders and champions do within our organisations, or the financial and structural support that helps make this vision more of a reality in our clinical practice. But a big part of it is also about how we as practitioners create and contribute to that culture ourselves. It's about creating that culture of openness and learning with each other in our teams, where there's opportunities where we can be trained together, we can reflect on what we're doing together, how we could be improving, but also for connecting with others round about us to help build that network of support for us, to build trust and cohesion that supports us to be vulnerable and open to ideas that don't quite work out as planned, or new ideas, and learning from each other as well. I think a lot of our fears come from about working more collaboratively with people and working in these person-centered ways, come from the feeling that we're kind of on our own. We have to have all the answers. We're on our own and we're not sharing that kind of learning with each other, and being vulnerable with each other as well. And all of these things contribute to what's called psychological safety and emotional culture, 2 things that you might have heard about before. And I guess none of this is new or a complete surprise, but I think what's new is that we've never really thought about what's happening in the culture and the organisation that needs addressing there, in order for us as practitioners to then spread and implement that more collaborative ethos of working together further upstream when it comes to actually delivering supported self-management, or working with people to support their self-management. And just ever so briefly, I wanted to touch on what this idea of psychological safety is. And I hope some of this resonates with you in your own working environments, or maybe in your own personal life, your own experiences of living with long-term conditions as well. We've probably all felt this and strived for it, and we may even have it, but just not think about it in these terms. And I've taken this from a book written by Adam Grant, who writes books about how organisations work and gives advice and recommendations for managers and leaders. But I think it resonates so well with what all of us can feel when we're working in our teams and in our health services to deliver rehabilitation and supported self-management. In particular, when we have the psychological safety, we work in a more open and transparent and perhaps authentic and honest way. We're allowed to make mistakes, and in fact these are seen as part of our learning and not a failure. They're not seen as a threat to our egos or our careers, but they're expected. And so they're built on, and we're encouraged to take risks. And that's an important part of supporting self-management, both from practitioners' perspectives in supporting people, but also from stroke survivors and their families' perspectives, and anyone with lived experience. Taking risks is part of how you learn, and taking risks is also how you work out what works and what doesn't, and what you're going to do next time. And it's this sense of psychological safety that allows us to also be open about what we're struggling with. And again, as we've been discussing, that's really important. All of our work is fraught with challenges, and creating that space where we can be open and learn from those and from others' experiences is essential. And we know we can be like this with our team members when we have psychological safety, because we have that trust in each other. We're not operating from a position of insecurity and fear. And again, I think that parallels so closely with what people with lived experience feel as well when they're tackling their self-management. And we feel more inclined to voice our ideas, put those on the table, both good and bad ideas, because we know that in voicing those, something will come from those discussions, rather than us being reluctant to stick our necks out. And for people with lived experience, for example, be reluctant to say what it is that they really want to work on or what's important to them. And this slide shows some quotes from our recent research, which provides evidence of how this can help to build practitioner confidence and courage in this case. Having that sense of psychological safety as healthcare professionals, where we've got that high degree of trust and openness, and when we have that positive emotional culture where everyone looks out for each other, is kind and checks in to see how each other is doing, those feelings go hand in hand. And having that in your team means that you can work together as a team better. You can connect with each other, you can find support in each other and advice and help each other out. And it's these connections and role modeling and seeing how others in the team work that can help build confidence and courage to take positive risks together, to innovate and change practice. And a lot of people with lived experience who engage with peer support groups will also talk about some of these things as well, that seeing others, building that trust, having that connections, that support there is what can build confidence and courage for them to take positive risks and to try out new things and to change the ways that they were maybe doing things before that are no longer working for them. And this slide is designed to test your knowledge of Disney Pixar characters. For those of you who are fortunate enough not to have to spend every Saturday or Sunday afternoons watching kids' films, then you lucky people. But to explain, the characters here are from a film called Inside Out, and they all represent different emotions. So we have anger, fear, joy, disgust, and sadness. And the reason I include this is because when I think of emotional culture in our healthcare teams, or the emotional culture that we have when we're working with stroke survivors and their families or other people with lived experience, the importance of understanding the emotions that our colleagues or whoever we're working with are bringing with them, it makes me think of this film. Emotional culture is defined as those shared affective values and norms and assumptions that govern the emotions that we have and we express at work or in a kind of situation where we're maybe working with stroke survivors and their families. And those good elements of how we work well together, either in our teams or as a partnership, having trust, openness, that confidence and effective communication, they're all grounded in the sense of emotional culture. People's emotions determine how engaged they feel, either at work or, for example, in their self-management. It also influences how they work well together and their experience of whether that working together is satisfying or if it's just actually leading to more burden and more burnout. And right now, for health professionals, as we pick up the personal and the professional impact of the pandemic within healthcare systems and try to shift things so that we're providing services that are meeting people's needs and expectations, I think it's important for how we work as a team and how we get on board with the changes that perhaps require a new shift in our thinking and our practice again, to have a good sense of the emotional temperature within our teams and those round about us. And so too do many of the stroke professionals that we've spoken to as well. And you'll see some quotes there about the importance of this sense of just checking in with each other and making sure that everybody's okay. And building that positive emotional culture can be as easy as modeling the culture of kindness and care that you would want to be part of yourself, ensuring that our words match our non-verbal expressions, and just asking how our colleagues, or if we're working with stroke survivors and their families, asking them about how they feel about things that they're doing or being asked to do, how they feel about working in different ways and the challenges that are arising for them as a result of that. Which brings us on to collaboration. And I'm going to start with a bit of a wish list here of the things that we know help to promote good relationships and partnerships with stroke survivors and health professionals, and which can help stroke survivors to build their confidence and their resilience and independence so that they can genuinely start to lead the way in their self-management decision-making and planning. And when I say lead the way, what I mean is they're not on their own with it. They're definitely supported, but that they're the ones with the power and the say over what's happening and what they want to be working on, rather than us as health professionals deciding. Sometimes the relationships that we build and enact with stroke survivors and their families are constrained by the structures and the routines of our day-to-day practice or the service delivery models that we're working in. And we sometimes can lapse into viewing these as transactional, that kind of means to an end, prioritising the hard technical aspects of what we're doing in terms of care delivery or rehabilitation over those softer aspects, like truly taking the time to genuinely get to know the person that you're working with. And we often view relational working as just part of what we do, rather than the actual essence of what we do and the thing that really makes the difference to people. And I've included this well-used and referred to quote here from Maya Angelou, which you'll all have heard of course, the American author and civil rights activist, because collaborative supported self-management should focus on not just what people can do, but how we're supporting them to feel as they recover and engage with rehabilitation and living long-term with any condition and the multiple conditions that they may be experiencing. And it's these things listed here that provide the building blocks of supportive conversations and trusting and authentic relationships with people that go beyond the practicalities of the day-to-day management, and they help to build a rapport with people, taking the time to truly get to know them, their values, and what their lives were like, in our case pre-stroke, but pre-conditions or pre-coming to us for help. What do they want their lives to be like right now? And building a rapport with people means that we can better support people in a more tailored and meaningful way, ensuring that we have the chance to offer the right support in the right way and at the right time. Without this understanding, our care delivery just becomes uniform and standard, and it's not personalised to people's needs. So it's no wonder that quite often they just feel like a number rather than a person. But it also helps to offer a sense of shared responsibility for self-management, where people don't feel like they're on their own with it, knowing that support's there when they need it, but also knowing that they have a part to play. Their contributions, ideas, and experiences are valued and welcomed and can be used to ground the provision of how we support people better. And the last thing here is sharing and learning from experience. And this involves both personal and from others, because when supported self-management becomes that process of self-discovery and navigation of the twists and turns of life, rather than just telling people what to do, it really helps to enhance people's problem-solving skills, working out for themselves what works, what doesn't, and how to pick up the pieces again when things don't work. That resilience, that strength of character, these are the things that supported self-management should also be helping with, rather than just the condition management or managing symptoms or whatever it might be. And I could talk till the end of the day about some of the incredible things that people have said to us about what happens when we genuinely and authentically take an interest in people, when we develop and prioritise those relationships with them and develop that sense of relational agency rather than individual agency where people feel that they're on their own with things. And when we recognise that there are limits to our professional expertise and we truly value the contribution and the impact that people's experiences can make, then it helps us to share that responsibility for self-management. And it helps us encourage learning and positive risk-taking, both from our side as health professionals, but also amongst people that we're working with as well. And people are more likely to feel that they're in an equal partnership with us when they have the opportunities to feel heard and listened to and truly supported in the ways that they want to be. And I wanted to just draw the talk today to a close by sharing the thoughts and experiences of this chap, Caleb Rickson, who lives in Australia. And he had a stroke at age 24. And he's very active in the kind of peer support and advocacy space. And he just kind of hits the nail on the head, really, for us health professionals about what we should be thinking and how we should be working. And I think it's so important for us to reflect on. And here's a wee picture of me getting to meet Caleb in Melbourne last month. It was a huge fangirl moment for me. I've followed his writing, his talks for such a long time, and I just think what he says is just what we health professionals need to hear more of. And we chatted for hours about supported self-management. I could still probably be there right now chatting with him if we didn't have real life to get on with. But I wanted to leave you with this idea. Supported self-management is more than just health professionals signposting or referring on to structured programs and interventions. It's supported through our everyday interactions and our conversations and relationships with people. It's supported through working with compassion and courage and confidence, curiosity and creativity, all these to build connections with them that allow our care to be tailored to their stories, to their values and experiences, and supports them to live their lives well and on their terms with a long-term condition, or in our case, after stroke. And finally, I wanted to introduce and acknowledge the people who've been involved in this programme of work with me, and who helped to make sure that our work has meaning and has impact on services and people's outcomes and experiences, and isn't just doing research for the sake of doing research. Some of you might know some of the faces in these photos, but I want to pay a special mention to our wonderful patient and partnership group who work with us, that you can see them there, Pat, Colin, Audrey and Betty. They are passionate advocates for supported self-management in stroke, and they bring the most amazing insights and experiences and fun to our work. I love catching up with them. They've got so much to share and have really been instrumental in pushing forward this programme of work round about supported self-management and how we can really make some genuine changes to what's happening in practice right now. And these are my details, and my email address is there as well, and a link to the project website, which will take you back to Glasgow University website, because that's where the project started, but that is the right place, and you'll find lots of information about the work that we've been doing, but also some videos, and you'll get some chances to meet our patient and public involvement group a little bit more. But do drop me a line if there is anything at all that you wanted to chat about after this. We've also got some final reports from the work that we've just recently finished, and I sent those to Barbara and the Alliance team, so they can be sent out to you should you wish to have a read of them. Thank you very much.